All right, chapter 15 is going to be on BLS resuscitation. So shouldn't be a whole lot here that we don't already know from our BLS part. So, but some competencies are applied fundamental knowledge, provide basic and selected advanced emergency care and transportation based on assessment findings for patient in shock, respiratory arrest, failure or arrest, cardiac failure or arrest, and post-resuscitation management. The principles basic life support and CPR were introduced in 1960. Specific techniques for the management of cardiac arrest and the guidelines for cardiopulmonary resuscitation emergency care, cardiac care have been reviewed and revised every 5 years, of course, and that's usually done by the American Heart Association. Uninterrupted chest compressions offer the best chance of survival while awaiting advanced life support intervention. Okay, so that's one important thing. I always try to keep those chest compressions going until ALS can get there, or use an advanced AEMT get there. So effective teamwork with good communication increases the potential for a positive outcome. So always try to communicate as a team professionally amongst each other, down from your layperson all the way up to yourself or the lead team, medic, paramedics themselves. Focus on your ABCDs, DEs. BLS is non-invasive emergency life-saving care used to treat medical conditions including airway obstruction, respiratory arrest, and cardiac arrest. So airway, breathing, circulation, disability, and exposure. I always remember trying to treat those first. So if the patient is in cardiac arrest, use CAV DE, sequence, compressions, airways, breathing, disability, and exposure. Only a second should pass it between the time you recognize that a patient needs BLS and the start of the treatment. All right, brain cells die every second that they are deprived of oxygen. Permanent brain damage is possible only after 4 to 6 minutes without oxygen. So if the patient is not breathing adequately or at all, you may restore normal breathing simply by opening the airway. I always try to use that acronym. When you think about trauma, try before you pry. You got a door closed on somebody in a wreck. Try to open the door handle. Same thing with CPR and stuff like that. Open up the airway. See if that's the problem. See if the tongue was in the way by some chance. And simply you can have an OPA in your hand and you open up the airway, or you can have that BBM in the hand and you do the hell teach you lift back and that opens up the airway. So if the patient has no pulse, you must combine artificial ventilation with artificial circulation. Your chest compression. All right, cardiopulmonary resuscitation establishes artificial ventilation and circulation in a patient who is not breathing or has no pulse. So CPR steps: open up the airway with jaw thrust or head tilt chin lift maneuver. Perform at least 30 high-quality chest compressions to a depth of 2 to 2.4 inches in the adult at a rate of 100 to 120 per minute to circulate blood to vital organs. Provide rescue breath via mouth to mask ventilation or bag mask ventilation. Administer 2 breaths each over 1 second while visualizing chest rise. All right. Quickly identify the patient who is in respiratory and or cardiac arrest and immediately begin BLS measures. ALS often involves cardiac monitoring, administration of IV or IO fluids and medications, and the use of advanced airway adjuncts. But when all this is done correctly, BLS can maintain life for a short time until ALS measures can be started. Okay, so don't never forget about your BLS. You might be the only one there, and you see somebody going in cardiac arrest. You have to send somebody after your stuff. At least then the adequate BLS is being done until you can get your stuff to have ALS started. All right. The components of CPR, American Heart Association chain of survival, is the ideal sequence of events that it can take. It can improve the chance of successful resuscitation of a patient who experiences sudden cardiac arrest. So there's 5 links: recognize and activation of the emergency response system. And this is why we try to teach the public on what to recognize the signs and symptoms and awareness of it. We use many, outlets to do that. So recognizing those early signs and immediately activating the EMS or the 911 system. Immediate high-quality CPR keeps the blood and oxygen flowing to vital organs. Chest pressure should be started as quickly as possible after cardiac arrest. So that's why we're doing the chest compressions only CPR, so that what's left, what little bit of oxygen is left, oxygen molecules that are bound to those hemoglobin molecules are circulating, and hopefully causing some type of exchange across those capillary beds. The rapid defibrillation, best opportunity for successful patient outcome. AEDs are readily available by anywhere now. Here locally, all of our fire departments are being paged out to cardiac arrest, to help hopefully get an AED out there quickly. So it does work. I've had the opportunity to be a part of that teamwork and had a successful outcome. So basic and advanced emergency medical services care provided by AEMT and other ALS providers before arrival to the ED. So it includes continuation of high-quality CPR, basic airway management, advanced airway management, manual defibrillation by paramedics, vascular access, possible pacing, medication administration. Post-arrest care includes cardiopulmonary and neurological support, additional medication therapy to support the blood pressure, so targeted temperature management, therapeutic hypothermia if that's readily available in your area, maintenance of blood glucose levels, cardiac catheterization, and electroencephalogram to detect seizure activity, admission to the ICU for critical care management. All right, if anyone of the links in this chain is absent, patient's more likely to die. Few patients survive cardiac arrest if CPR is not done and within the first few minutes. As soon as resources permit, IVIO access should be established. A patient may be hypoglycemic and administering dextrose may help with the ROSC. Let's talk about the 5H's and 5T's mnemonic. This is described by the American Heart Association to determine possible reversible causes of cardiac arrest. I highly recommend you start to know these. That way, if you get into that cardiac arrest situation, you're trying to figure out what's going on. Maybe there's something I can miss. Think about the 5H's, 5T's. So highlight these in your book. Hypovolemia of some sort, hypoxia, hydrogen ion with acidosis, hyperkalemia, hypothermia. Just try to remember, do not dead to the woman dead. Tissue pneumothorax, cardiac tamponade, toxins, and thrombosis, both cardio and pulmonary. So try to think about all these, what could be causing it, what couldn't be causing it. This shows algorithm for providing advanced cardiac life support. So start CPR with chest compressions, administer the O2, attach the AED. You're gonna go into an algorithm of checking the rhythms. If VTAC, start your shot these rhythms at the advanced EMT level. You have to be in the AED mode, and the AED has to recognize the VFib and VTAC. High quality CPR in cycles of 32 with rotating compressors every 2 minutes and a maximum of 10 seconds interruption. And that's just, make sure that you rotate people out every 2 minutes of the cycles. So perform continuous high quality CPR. Your chest pressure is really important. At a rate of 100 to 120 compressions per minute. So, and assist ventilation, every 6. All right, establish your IVIO access. Consider advanced airway. You think about your capnography if possible. If you have that available, either waveform or colorimetric, and treat reversible causes. That's where your 5H's and 5T's come in. Check the sugar. See if they something with toxins. Maybe administration Narcan. Something. Thrombosis maybe. With ventilation, make sure you give at least 6 breaths per minute. So, they may not be incomplete, complete synchronized with your compressions, but think about that also. Transport these patients if necessary, according to your protocol. If you do, you get Ross back. Think about that. We're gonna get fluids. We're gonna get the blood pressure up. Do your 12 leads if that's all available in your local area. So you want to integrate that post-cardiac, post-arrest care. There's some hypothermia available, things like that. If you don't get anything back, it may be time to terminate efforts. You may need to contact medical control. Follow your local policies and procedures. I know in the state of North Carolina, you have the right to, after 3 rounds of medications with an advanced airway in place that is confirmed. But that's also going to be, per your local medical direction also. So you need to understand those policies and procedures too. All right, always begin with surveying the scene. Look at the scene. You may have that patient that's possible toxins overdose. Determine why this patient is unresponsive and not breathing. No pulse. So you see what's going on, see what's around, different things like that. Make sure you always stay safe as far as you and your partner. So, what's your initial impression? Bystanders, are they around? If they got some information they may be able to give you, even if it was somebody that found somebody inside of a house. They may be able to give you some information about that patient. What's making the injury, nature of the illness? Do you suspect trauma of any sort? Does dispatch information match what you are seeing? Do you need additional help? Please. So now you'll go into your ABCs. That patient on show, ask if you're okay. Of course, they look apneic compulsive. That's not gonna happen. Take your spinal cord from further injury, cervical spinal injuries present. If you do encounter cardiac arrest, patient while make sure you call 911. All right. Basic principles BLS are the same for infants, children, and adults. If a child is less than 1, child between 1 and onset of puberty, 12 to 14 years of age. Adulthood is from onset of puberty and older. Cardiac arrest in adults occurs before respiratory arrest. So respiratory arrest usually occurs before cardiac arrest in infants and children. Might be a good point to remember there. I always think respiratory with infants. Usually it's a respiratory problem, compromised situation of some sort. Think of that before cardiac with children. All right, AEDs. Most pericardic arrest often occur as a result of sudden cardiac rhythm disturbance, dysrhythmia, such as ventricular fib, fibrillation, VFib, VF, or pulseless ventricular tachycardia, VT, VTAC. Important thing there is pulseless VTAC. So keep that in the back of your mind, because there is a difference, and there is a difference in treatment. So whether you have a pulse or no pulse with VTAC, if you see that on the monitor. Normal heart rhythm is known as sinus rhythm. It originates in the sinoatrial node. BFib is disorganized quivering of the ventricles. It is generated by exotic foci, resulting in no forward blood flow and a state of cardiac arrest. BFib is when the heart's just sitting there quivering inside the chest. It looks like it's having a seizure a lot of times. VTAC is rapid contraction of the ventricles that does not allow for normal filling of the heart. So you see a rhythm, you see some kind of, you see a rhythm there, as far as the heart, the mechanical part of it, but it doesn't give the heart time to fill the ventricles to be able to push the blood out. Early defibrillation is linked to the chance of survival, most likely important to survival rate. So likelihood of survival decreases rapidly over the time as VFib and pulse VTAC persist. So when a patient is in cardiac arrest, begin CPR, start with high quality chest compression, and apply the AED as soon as possible. AED usage in children safest if using pediatric sized pads and a doses and attenuating system, an energy reducer. And most manufacturers do have that in their setup for those. Set up in their AED. But however, if those adults, if you don't have the pediatric emphasized pads, if you don't have, I wouldn't recommend infant pads. Using adult pads in replace of infant pads, because the chest area itself, I don't think the adult pads will fit very well. Now, if you got an infant that's kind of large, use your adult pads. But make sure you always follow the manufacturer's instructions on the usage of this stuff. Okay. This says use the adult size pads anterior posterior if the pediatric size pads are not available. Apply after the first 5 cycles of CPR. After the first 5 cycles of CPR, use the AED to deliver shocks in the same manner as with an adult patient. So for an infant between 1 month to 1 year of age, a manual defibrillator is preferred. When you get to the paramedic level, you will understand, joules per kilogram and how to make that conversion. So, but for right now, call for a paramedic backup quickly and immediately if you suspect the infant to be in cardiac arrest. If paramedic backup is with a manual defibrillator is not available, AED is equipped with a pediatric-sized pad and a dose attenuator, which reduces the joules based off of the size of the patient. Okay, it's preferred of an adult-sized pad. So monitors now are biphasic monitors. They read the impedance between the two pads, and that is basically the space of mass between the two pads. So when you put that dose attenuator, that dose reducer on these AEDs, it tells the AED to read that impedance, and so that the joule sets can start going down and possibly shock that patient at the preferred joules. All right, special AED situations, pacemakers, and implanted defibrillators. You may have a patient who has an automated implanted cardioverter / defibrillator. They're recognized by a heart lump in the upper left side of the chest. If the AED electrical pads are placed directly over the device, the effectiveness of the shock may be blocked. So place the AED at least 1 inch, 2.5 centimeters away from the device. And occasionally, the implanted device will deliver shocks to the patient. So if you observe the patient's muscles twitching As if shocked, then continue CPR and wait 30 to 60 seconds before delivering a shock. Water. Do not use the AED in water. Okay. Electricity flows through water. All right. I hope that's self-explanatory. If the patient is in water, pull him or her out of the water and dry the skin before attaching the AED. Also, make sure your patients are not laying in a puddle of water. Okay? You want to make sure that that's not happening either, because that electricity can travel through that water. It can cause a significant dent around that patient. Don't delay CPR to dry the patient thoroughly. Instead, quickly wipe off as much moisture as possible from the chest. So if the patient is in a small puddle of water or in the snow, the AED can be used, but the patient's chest should be dried as much as possible. So, but make sure that we use pads now. Sure that those pads completely on that patient. Be very, very conscious of that. Okay, you don't want no arcing, no possible displacement of electricity going somewhere. Hair, you may encounter a patient with enough chest hair to prevent the AED from adhering to properly. So you may receive a check electrodes or check pads error message from the AED. EMS providers generally carry small razors for removing hair. So you will not be available if your respondent has a layperson. So quickest way to remove hair is to press the AED's pads firmly against the chest in the appropriate area and quickly pull them off. So you may want to ensure that you have at least 2 sets of AED pads before using the first set of pads to remove the hair. Use that set to remove a bunch of hair. Then you don't have another set. So transdermal medication patches may encounter a patient who's receiving medication through transdermal medication patch. The patch can block the electrical current and cause a burn to the skin. Remove the patch and wipe the skin to remove the medication residue prior to attaching the AED pad. Positioning of the patient. So for CPR to be effective, place the patient must be lying supine on a firm surface. There must be enough space around the patient for 2 rescuers to perform CPR and use the AED. If the patient is crumpled up or lying face down prone, you need to move him or her to a supine position with attention to cervical spine control if a potential injury is suspected. So if possible, log roll the patient onto a long backboard as you position him or her for CPR. So this will provide support for CPR and offer an easy medium for moving the patient as needed. Okay? So applying that backboard kind of does 2 things at one time. It's going to help you move that patient from one spot to another, but it's also going to provide you that hard surface to do chest compression effectively. All right, visualize the chest. For signs of breathing while palpating for carotid pulse. So once you make sure that patient is unresponsive, check for both. Feel for the carotid artery by locating the larynx at the front of the neck, the anterior side, flying 2 fingers towards the side you're closest to. Okay. Pulse is felt in the groove between the larynx and the sternocleidomastoid muscle with the pads of the index and middle fingers held side to side. So the light pressure is sufficient to palpate for the pulse. Providing external chest compressions if the patient is not breathing and it does not have a pulse. Again, CPR, start with chest compressions. Chest compressions are administered by applying rhythmic pressure and relaxation to the lower half of the sternum. The heart is slightly located to the left of the middle of the chest, between the sternum and the spine. Compressions do squeeze the heart, and it has a pump, the mechanical device, to circulate the blood. Circulating only 1/3 of normal heart pump blood, and do not lean on the chest between compressions. Allow that chest to come completely up from recoil so that blood can actually refuel the ventricles and be able to be pumped out. So proper hand positioning and compression technique is established by placing the heel of one hand on the sternum in the center of the chest. Complications from chest compressions are rare, but can include fractured ribs, a lacerated liver, and a fractured sternum. Using good technique can minimize this stuff and proper hand placement. So you need to be in a smooth, rhythmic, and be uninterrupted as much as possible. So short jabbing compressions are not effective by producing artificial blood flow. So do not remove the heel of your hand from the patient's chest during relaxation. It's more dangerous to compress the chest too lightly than it is to compress too forcefully. So push hard and push fast, and switch compressors every 2 minutes. So basically, this should be rhythmic. It kind of shows you that your hand remains on the sternum so that you come completely up and allow that chest to recoil. As an ALS provider at the advanced EMT level, you may be in charge of a cardiac arrest situation. You may be that highest level of care there. Sometimes it's hard to. You need to be able to critique people, even a layperson, your first responders, your EMTs, with proper chest compression. A lot of manufacturers of AEDs and heart monitors have come out with a device that you can place in the chest so that you get that mechanical look also, and it kind of helps coach chest compressions too. But sometimes you may not have that device there and readily available. You may be the one that you say, hey, look, we need to go faster with chest compressions and we need to go deeper. Don't be scared to compress all the way down. We got to go about 2 inches, 2.5 inches down. And they may be sitting there bouncing on the chest and not allowing that recoil either. And, you might be the one that needs to coach whoever's doing chest compression. So that person is acting as the mechanical function of the heart, helping that blood flow. All right, opening the airway uses 2 techniques: head tilt, chin lift, jaw thrust maneuver. It's designed to bring the tongue forward and off of the back of the throat. So, used when there's no indication of spinal injury with the head tilt, chin lift. Patient has no sustained trauma. If the patient does have foreign material or vomitus in the mouth, quickly remove it via suction. Solid materials may be removed using your hook index finger. If it's not available, roll the patient on the spine and try to remove the foreign material. Jaw thrust is used if you suspect spinal injury. Place your fingers behind the angles of the patient's lower jaw and then move the jaw upward. Keep the head in a neutral position as you move the jaw upward and up in the mouth. If the patient's mouth remains closed, use your thumbs to pull down the patient's lower lip. So the recovery position is used for a patient to be able to breathe on his or her own, showing no signs of injury to the head, spine, or hip or pelvis. So it helps maintain a clear airway in a patient with a decreased level of consciousness. Allows vomitus secretion to drain from the mouth. So place the top hand under his or her cheek. Never place a patient who has a suspected head or spinal injury in the recovery position. Breathing is the lack of oxygen hypoxia combined with too much carbon dioxide in the blood, hypocarbia, is lethal. Ventilation should be delivered over 1 second, and it prevents air being forced into the stomach, resulting in gastric distension. Stoma ventilation. Stoma is open that connects the trachea directly to the skin. Patients who have undergone a laryngeectomy often have permanent tracheal stoma at the midline of the neck. Patients with a stoma should be ventilated with a bad bowel mask or pocket mask device placed directly over the stoma. If air leakage through the nose and mouth interferes with ventilation, cover the nose and mouth with your hand to make them still. Use pediatric masks to ventilate through the stoma. Okay. These patients have stomas. Use them. They're a direct line to the trachea. Gastric distension. Artificial ventilation may result in the stomach becoming filled with air, a condition called gastric distension. It's likely to occur if you hyperventilate the patient, so it's important to give slow, gentle breaths. Massive gastric distension interferes with adequate ventilation and contact medical control. Gastric distension, a lot of times it comes into play when you have initial people coming in to do CPR and artificial ventilation, and they get in a hurry. When you arrive on scene, you may need to look at the stomach and see if it's distended and it feels like a brick wall. Sometimes what I describe it as. So just take a look at it. All right, when providing CPR alone, provide a continuous cycle of 30 chest compressions followed by 2 artificial ventilations with that 30. 2 rescuers to adult CPR is less tiring and facilitates effective chest compressions. Switch rescuers during CPR to maintain high quality compressions. So second rescuer should apply the AED, set up airway adjunct, and insert a oropharyngeal airway. So first rescuer completes that first cycle of 30 compressions. Then, he moves to the head and gives them 2 breaths. Second rescuer moves into position to provide chest compressions. So then you're doing 2 rescuer CPR. So that's 5 cycles, about 2 minutes. Rescuer provides compressions. We'll begin the tire switch, but that should last less than 10 seconds, and you go through the switch. Team members that work together with a team leader to develop and maintain a shared understanding of the emergency situation. A lot of times, your team leader, you try to go into these with the picker approach. So it can be particularly effective in cardiac arrest resuscitation. So each member is assigned a particular role prior to treating an actual patient in cardiopulmonary arrest. A lot of times there's only 2 of y'all there on that truck. So, you need to be able to pick what you want to do versus what you don't want to do. A lot of times when I'm on the truck, I say, look, you want the heart or you want respiration. So that way, when you get there, you kind of know what each other's doing. So you want to approach it with a pit grill determination. So crew resource management is the way for team members to work together with the team leader to develop and maintain a shared understanding of the emergency situation. It allows team members with different skill sets to collaborate and communicate, fulfill their roles and responsibilities, and achieve the shared goal of the best possible patient outcome. So each member is responsible for maintaining situational awareness of the patient's current condition and sharing any crucial information with the team leader. The team leader is responsible for listening to any crucial information and incorporating it into his or her decision making. You want to use the PACE mnemonic, PACE probe, look or ask to confirm the problem. Alert, communicate the problem with the team leader. Challenge if the issue is not corrected. Challenge the teams present course of action. Emergency if the problem is clear or uncritical. And immediately communicate the emergency to the entire team. So, co-team member roles. The ventilator manages the airway, suction the airway, ventilating, and certain advanced airway device, maintaining manual inline stabilization of the head and neck. Active compressor provides high quality chest compression. Responsibility to compress for 2 minutes and be on deck compressor for 2 minutes. The on deck compressor assists with application of a mechanical CPR adjunct device if it is available. A device that will do the chest compressions for you. Assess vital signs, prepare the patient for transport. Other support personnel responsible for operating the AED, scanning, venous IVIO access, and also possible documentation for patient care report. So, a lot of times we leave our BLS people to do chest compression while we're there getting the ALS stuff, secured and done. The co-team leader must know all of the specific skills and be able to expertly perform each skill. Is often responsible for ensuring everything gets done at the right time and in the right way. Must model excellent behavior and leadership skills for their team and all others who may be involved in resuscitation. So roles may include obtaining the patient's history and performing the physical exam, keeping the track of time, making a medication decision following the algorithm, clearly delegating tasks to co-team members, completing documentation after resuscitation attempt, and talking with medical control and controlling the resuscitation. All right, post-resuscitation support. It is an important component of care for cardiac arrest patients. An effective cardiac rhythm is restored in the field, provide immediate transport. During the transport, the blood pressure, patient's blood glucose level, and ensure effective ventilation. But always leave your AED in place. You need to be able to optimize ventilation and oxygenation, maintain the saturation above 94%. If you do have capnographies, and even to the waveform capnography, place that on there. Don't hyperventilate these patients. Keep your pulse ox up. Keep your capnography between 35 and 45, and that way you're providing those benefits to the patient. So, treat hypertension. Maintain that systolic blood pressure around 90 or below with IVIO boluses. Several devices and techniques to assist circulation. Active compression, decompression, CPR. So compression of the chest, then actively pulls it back up into the neutral position. Features a suction cup that is placed in the center of the chest. After compression of the chest is proper depth, the rescuer pulls up on the handle of the device to provide active decompression of the chest. So ITD valve device placed between the ET2 and the battery valve mask limits the air entering the lungs during the recoil phase between chest compressions, helps improve circulation during CPR, and increases velocity and cardiac arrest patients. Mechanical piston devices decompresses the sternum via the compressed gas powered or electrical power plunger mounted on a backboard. Patient's position supine on the backboard with the piston positioned over the top of the patient and plunger centered over the patient's thorax. So the mechanical device allows rescuers to compete with the depth and rate of compressions, resulting in constant delivery. These are nice devices. They come by many manufacturers. If you have one, they do help in a cardiac arrest situation as far as manpower also and as far as tiredness. If in the child CPR, cardiac arrest in children usually follows respiratory arrest. Always think about that. Always think about in infants and child state respiratory nature. Focus first on opening the airway and providing artificial ventilation. Determining responsiveness in child. Never check a child to determine responsiveness. Gently tap the child and say loudly, "Are you okay?" When the infant gently tap the soles of the feet. So if you find unresponsive adequate parts of this child, we perform CPR, beginning with chest compressions for approximately 5 cycles, about 2 minutes, and then stop to call 911 and retrieve an AED. Children require immediate restoration of oxygenation, ventilation, and circulation. Okay? So get your child, find them, do your 2 minutes, and then try to go find AED. Because 9 out of 10 times it's usually a respiratory compromise of some sort. So getting that circulation of the O2 molecule is important. So check breathing and pulse. Visualize chest for signs of breathing. Palpate the pulse in the large central artery. And infants palpate the brachial artery. Children, you can palpate the carotid artery, same as you would for an adult. Chest compressions in an infant, place the infant on a hard, flat surface. Your forearm and hand can serve as a flat surface. Use the palm to support the infant's head. Use only 2 fingers to compress your chest. So if the 2 rescuers are performing CPR on an infant, use the two thumb and circular hands technique to deliver chest compression. So in children, use the heel of one or both hands to compress the chest. So if you're working alone, always remember 32 is your ratio. If you got 2 people, 15 to 2 is your ratio. So make sure that chest does fully recoil for infants and children. Far body obstruction of the upper airway in advanced pathology is common, and they're often put toys and other objects in the mouth. Make sure the upper airway is patent when managing pediatric respiratory emergencies or cardiopulmonary arrest. If the child is unresponsive for breathing adequately, place the child in a recovered position and maintain the upper airway. Opening the airway in an infant or child is done by using the same techniques as for an adult. So if you suspect a spinal injury, the jaw thrust maneuver is the best method. If you do not suspect spinal injury, use the head tilt chin lift maneuver. To modify that as you tilt the head back. Move it only into the neutral position. Okay, you don't want to hyperextend the neck because it will cause a blockage of the trachea due to the proportional size of the head being greater. All right. Rescue breathing. If a child has a pulse, 1 breath every 35 seconds. Child doesn't have a pulse, 2 breaths after every 30 compressions. Okay. So basically that's 12 to 20 breaths per minute for a child. So child with tracheostomy tube in the neck, remove the mask. Fund the bivalve mask device and connect it directly to the tube. Make every effort to maintain a chest pressure fraction of at least 60%. Okay. That means that 60% of the time of you having that patient, you'll do a chest compression. All right, we're not to start CPR. There are general exceptions when CPR should not be started. Seen as unsafe. Okay, obviously. You don't put yourself in a safety compromise. If the patient has obvious signs of death, including the absence of pulse and breathing, along with rigor mortis, dependent lividity, mortal injury such as decapitation, dismemberment, or burn beyond recognition. Crucifixion too. Okay. Okay. Rigor mortis is hardening of the limbs where they're hard to move. This means this patient has been down for a couple hours at least. So that means that these patients have been down for longer time and have probably even if trying to, they've probably got a hypoxic brain injury. So it's really not good to even try to attempt those situations, attempt chest questions and CPR on those situations. Dependent lividity is what you're seeing here in this picture. And this lividity is been here for an extended time, also due to the blackness of the posterior area here. Lividity starts out has pulling of the blood onto the side on which the patient's laying. This patient should have been laying on their back, but that starts several hours after death has occurred. A mortal injury, decapitation, dismemberment, or burn beyond recognition. Don't try to start CPR on those patients. All right. Also, patient has physician have previously agreed DNR on order, the no CPR order. So usually only applies to a patient in a terminal stage or incurable disease. Can be a complicated issue. Can be a very complicated issue. Advanced directed expression the patient wishes may be hard to find. So you may encounter physician orders for life-sustaining treatment or medical orders for life-sustaining treatment also. These are legal documents describing acceptable interventions for the patient in the form of medical orders. So it must be signed and authorized by medical control. I always start CPR without it. Okay. DNR is the most forms, the only two forms that in the state of North Carolina we can follow. Make sure that you go by your policies and procedures and by the state guidelines and statutes. So please understand that. We only follow most forms and DNRs. Patients got living wills and different things like that. I'm not saying don't call medical control. The family's very adamant about it. Call medical control, tell them what you got. So that way, at least you've got that back into. When to stop CPR. Once you begin CPR continues to one to follow. Patient starts breathing, has a pulse. Patient is transferred to another trained responder. You're out of strength, and a physician will assume responsibility for the patient that directs you to discontinue. Okay. So CPR should be continued until patient care is transferred to a physician or higher medical authority in the field. Your medical director or designated medical control physician may order you to stop CPR on the patient's condition. All right, airway obstruction may be caused by relaxation of the throat muscles, vomiting, stomach contents, blood, damaged tissues, dentures, and foreign body. Large objects that are visible but cannot be removed from the airway. Suction should be swept forward and out with your glove index finger. Suctioning can be used as needed to keep the airway clean of thinner secretion. Recognizing foreign body obstruction, mild airway obstruction, able to exchange air that still shows signs of respiratory stress. Encourage the patient's cough. Do not interfere with the patient's own attempts to expel the foreign body. Observe for signs of severe airway obstruction, weak or absent cough, decrease in the level of consciousness, and silent motion. A responsive patient, easy to recognize when someone who is eating or just finished eating. The person is unable to speak, cough, grasp the throat, turns cyanotic, and makes exaggerated efforts to breathe. Ask the patient, are you choking? Hands at the throat is the universal choking sign. You may hear high-pitched sounds called stridor, and it indicates minimal air movement. An unresponsive patient may be determined first telling the patient's breathing has a pulse, suspect an airway obstruction if the standard maneuvers to open the airway and ventilate the lungs or not. So, abdominal thrust maneuver is recommended in responses adults and children older than a year. Creates an artificial cough by causing a sudden increase in intrathoracic pressure when thrusts are applied to the subdiaphragmatic region. Okay, so right below the diaphragm, like you see up at the top picture with the lady in the black t-shirt. So a very effective method for removing a foreign body obstruction in the airway. The patient is severe airway with severe airway obstruction is unresponsive to perform your chest compressions. Abdominal thrust maneuver, the goal is to press the lungs forward and creation upward and force residual air out of the lungs to flow upward and expel the object. So, stay behind the patient, wrap your arms around, straddle with your legs, make a fist with one hand, grab the fist with the other, and just above the umbilicus and below the xiphoid process. So thrust inward and upward. Chest thrust, this is used in advanced stages of pregnancy and patients with obesity. So same thing, make a fist with one hand, grasp with the other. Place the thumb against the patient's sternum, avoiding the xiphoid process. Place your fist in the patient's chest with backward thrust until the object is expelled. Okay. They become unresponsive, start CPR. Responsive patients become unresponsive in CPR, start with chest compressions because this is a witness arrest. By you, carefully support the patient to the ground and immediately call for help. Perform 30 chest compressions and do not check for pulse performing chest compressions. Open airway and look in the mouth. If you can see an object that can be easily removed, then remove it with your fingers and attempt to ventilate. If you do not see an object, then resume chest compression. Repeat steps to those second or third steps till the object is released or paramedics take care of. Unresponsive begin CPR. Determining responsiveness, think about your 5 H's and T's, and checking for breathing and pulse. Pulse is present, but breathing is absent. Open the airway and attempt to ventilate. If the first ventilation does not produce visible chest rise, reposition the airway and reattempt to ventilate. If both ventilation attempts do not produce visible chest rise, perform 30 chest compressions and then open the airway within the mouth. The object is visible and then it can be easily removed. Remove it with your finger. Never perform block finger sweeps on any patient. Continue the sequence of chest compressions, open airway, look inside the mouth until the patient is airway is clear or paramedics. Foreign body airway obstruction in infants and children usually caused by foreign body airway, such as food or a toy or an infection. If patients have signs and symptoms of an airway infection, Do not waste time trying to dislodge a foreign body. Administer supplemental oxygen if needed, and immediately transport the child to the ED. Those children need help as far as antibiotics and different things like that. A previously healthy child who is eating or playing with small toys and suddenly has difficulty breathing, has probably aspirated a foreign body with mild airway obstruction. The child can cough forcefully, although he or she may wheeze between coughs. As long as they breathe, let them cough, let them do what they got to. Encourage the child to continue coughing and administer supplemental O2 if needed and transport. Intervene only at the time of a severe airway obstruction develops, such as a weak, ineffective cough, cyanosis, stridor, absent air movement, or a decrease in level of consciousness. Removing a foreign body, airway obstruction in a child. So if the patient is responsive, kneel on one knee behind the child and circle your arms around the child's body, give the child abdominal thrust in an upward direction. Repeat this technique until the child expels the foreign body or becomes unresponsive. Child becomes unresponsive. Position the child on a firm, flat surface and immediately call for help. Give 30 chest compressions using the same landmark you would for CPR. So do not check for pulse before performing chest compressions. Open airway, look inside the mouth. If you see an object that can easily be removed, then remove it with your fingers and the tip to ventilate. So if you can't see the object, then resume chest compressions. Repeat steps until the obstruction is relieved or paramedics take over. Unresponsive child, older and worn with airway obstruction becomes unresponsive. He or she is managed in the same manner as an adult. Okay, so unresponsive infants begin CPR with chest compressions. Do not check for pulse before starting compressions. Open airway, look inside the mouth. If you see the object, it can be easily removed, then remove it. Remove it with your finger and attempt to ventilate. Okay, if you do not see the object, resume chest compression. All right, some special circumstances: opioid overdose. Opioid is that narcotic drug depresses the central nervous system. It causes decreased ventilation, causes respiratory arrest followed by cardiac arrest. In these situations where opioid overdose is suspected, bystanders may have administered naloxone or Narcan. So, Narcan blocks opiate receptors in the body and reverses the effect of opioid overdose. Naloxone auto-injector devices intended are now available in the U.S. Determine how much of the medication was given and the route by which it was given. Administer more Narcan through local protocols written in case of suspected opioid overdose. Standard resuscitative measures take priority over Narcan administration. Don't delay interventions while waiting for a patient. Wait with patients to respond to Narcan therapy. Sometimes it depends on how much they actually took and how much Narcan can actually get into the system and reverse those effects. So many patients who have overdosed on an opioid have a pulse but are not breathing, bad mouth, back mask ventilation is the most critical treatment, followed by administration of Narcan if it is available. A couple more things with Narcan. It can be given, they're giving it out IN, intranasally. They are doing the needle injections now. That's out there. So, don't be surprised what people tell you Narcan, how it's being administered. by a layperson. Cardiac arrest in pregnancy. Um, Provide high quality CPR, relieve pressure off the aorta and vena cava. Patient not in cardiac arrest, position her on the left side to relieve pressure on the great vessels. So perform manual displacement of the uterus to the patient's left to relieve compression of the great veins while CPR is being performed. Improve the effectiveness of compression. All right. Quick support for family members and loved ones. Okay. In some cases, family members may experience a psychological crisis that turns into a medical crisis and becomes patients themselves. Okay. Patient that is grieving due to a death can experience some type of medical crisis. So they're complaining about something, they become a patient, then also they need to be checked out. Stress does induce other medical conditions. Families do not typically expect EMS providers to stop resuscitation and leave their loved one on the scene. So when death appears imminent and resuscitative efforts are unsuccessful, make the family members aware if the patient is not responding to the treatment. So discuss with them what is happening so that they may be better prepared for the inevitable. Keep family members informed throughout the resuscitation process because it may also help them feel more control. Sometimes we have to tell patients, families, friends, and bystanders that we are stopping resuscitative efforts due to following our local policies and procedures. That allows us to do that. ACLS at our level is a lot like ACLS in the hospital now. So all the same things that are being done by doctors and nurses inside the hospital are being done out in the field. And a lot of times you just have to make family and friends and bystanders understand that. Sometimes they don't understand why you're not doing anything at all. So, you have those guidelines as far as withholding resuscitative efforts. You may have to explain that also, why you're not doing anything to help that person, that patient out. Education and training for the advanced AEMT, like a skill, CPR skills are deteriorate over time. Practice these skills often using medicine-based training, ideally frequently with the standard certification that occurs every 2 years. Always use high fidelity, expensive mannequins for CPR training. Still take the training to ablate people in the critical skills of CPR and IED operation. So try to educate families to recognize cardiac arrest and train them in compression zone and CPR. Your agency, a lot of times we get out there and at different events, allow you to train people in chest compression only CPR. Okay, that's the end of chapter 15. Thank you. All right, remember foreign body airway obstruction in infants, responsive infant, abdominal thrusts are not recommended for a responsive infant. So do your back flaps and chest thrust. Removing a foreign body airway obstruction in infants, hold their face down with body resting on one forearm. Deliver 5 back blows between the shoulder blades using the heel of your hand. Place your free hand behind the infant's head and back and turn the infant face up on your thigh, keeping the head in from below the body. So give 5 quick chest thrusts on the sternum, same location as manner of chest compression. So using 2 fingers placed on the lower half of the sternum. Check the way if you see the foreign body, remove it. If not, repeat the cycle as often as possible. If the infant does become unresponsive, do your CPR. Use a barrier device when you administer ventilation in the pre-hospital environment, such as pocket mask or bag mask device. Use devices that supply supplemental oxygen when possible. Observe the chest for visual rise and fall to assess the effectiveness of your ventilation. Resuscitation of a neonate is discussed in Chapter 35. High ventilation may cause an increased intrathoracic pressure, and that can reduce the amount of blood that returns to the heart. Decrease the effectiveness of chest compression results in heart and brain receiving decreased amounts of oxygen. Rapid forceful ventilations increase the risk of gastric distension, and this may result in expulsion of gastric contents and aspiration of fluid or vomitus into the lungs. So, you force a bunch of air in there at one time, you could possibly force some of it into the stomach. The stomach does not exchange air at all. Once you pump the stomach up so much, stuff's going to come back up and out. Okay? Either it's going to vomit out and you're going to see it, or you could even possibly cause aspiration, which it partly comes out and back into the lungs via the trachea.